David, good morning. How are you?
Hey, David, how are you? And I know to your right or to your left is my good friend and mentor, Bill O'Neill. Am I correct?
Bill is in the house.
Okay.
I just saw him and reminded him that we have a live case.
All right, good.
He brought some of the rain from Detroit, unfortunately.
I saw that.
But yes, he is here. Tom Wagner here. Matt Sherwood. We're going to have Mike Lim and Jazz Singh join us. But yes, Bill is working his way up.
You're very lucky to have Matt Sherwood on the panel because when Herms and I did a dextrocardia at the last live SIF, Matt was the only one who picked up that it was a dextrocardia. So you've brought in a ringer, no question about it. Hey, let me introduce the room. To my left, someone who really doesn't need any introduction. To me, one of the premier CTO operators that I've ever had the honor to work with. I always learn so much from Ashish when he and I work together. Thanks for agreeing to do this with us.
My pleasure. Looking forward to it. Thanks for inviting me as always. Thank you so much.
We have a lot of clinical support in the room, but I will just tell you, we have Kenzie, who scrubbed with us yesterday, did a fantastic job. We have Mallory, and we also have Colin in the back, and we have Matt just administering some conscious sedation so we don't have to think about it this case.
Dave, Bill has just joined us, so we got all the horses in the starting gate.
Yeah, but
Awesome.
you got the stallion in Bill O'Neill. So, Bill, how are you?
In from late from Detroit last night, but thrilled to be with you.
And not as thrilled as we are to have you with us. So thank you, Bill.
Ditto.
So why don't we put up our slides, and we're going to go real fast through the slides and then throw over to Alok because he's got a terrific case, several terrific cases. There's a theme to yesterday and today's cases here in Lab 2 in our Siemens lab. Yesterday, Bill, it was what happens when you get a balloon across the lesion, but it doesn't dilate. And we went through a whole algorithm of things, and we ended up shockwaving it. Today, Ashish and I decided on a case, so what do you do when it's a balloon uncrossable, when you can't get through the lesion? So this is an 84-year-old, multiple risk factors for heart disease, a history of atrial fibrillation, presented with an ACS, and the right coronary artery, you can go to the next picture, the right coronary artery has these serial lesions. The operator was able to get a wire through there, but couldn't get anything else through there, Ashish. So he called and said, what should I do? And I said, you should take the patient off the table because this is a perfect case for a perfect instruction case for Scottsdale interventional form. Ashish, next slide. You have, go to the next slide, please. Ashish has an algorithm just in 30 seconds.
Yep. So I don't want to take credit for the algorithm. I think this algorithm was actually put in place and published by Robert Riley when he was a fellow with Bill at University of Washington a few years ago. We talked about different things that you can do. So I call it the 10 steps when you have a balloon uncrossable lesion, and I think it's a great slide for the audience to take a little picture off and keep in their back pocket because you come across this every day.
So, I'm sorry.
Just increase your guide support, step number 1. Number 2, try a small balloon. Number 3, switch to a different microcatheter if your microcatheter isn't going. Number 4, try a balloon-assisted microdissection, which is basically blowing up a balloon. There's some tricks to doing that. A small 1.0, 1.25 balloon, usually 20 millimeters in length. You could try a stiffer microcatheter if sometimes the smaller profile microcatheter doesn't go. Then and the last step is essentially when you have wire across the lesion, you could try laser. The steps that are 7, 8, 9, 10, and 11 are steps that you have to give up the wire for. So those are a little bit more advanced.
And you always tell me you love the laser bailout option, don't you?
Because the reason I like it is because you don't have to give up wire position.
Okay.
Because to me, that is like the advantage of having the laser. All other options, if you're not talking about external cap crash going retrograde, doing free wiring with the roto, et cetera, has an element of risk where you may or may not be able to rewire the lesion, especially if you've disrupted it in some way.
So show them where we are so far. We're using the Asahi sheathless guide.
Yep.
So just explain what you've done so far.
Yeah, so it's interesting. So we made our own side holes for the AL 0.75 Asahi sheetless guide. It's 7 French because we were not sure if we needed to upsize to a 175 or a 2 Burr if we do need to rotablate. We wired it with a jacketed 014 wire. Sheon Black is sort of the wire of choice here for me. And we supported it with a pretty robust, sturdy microcatheter, the Turnpike spiral with the grooves to see if I could get some extra purchase as I spun it. Our challenge in this case, as you can see from the image, is our guide, even though is probably the right guide for the case in terms of support, it still is not exactly coaxial, and the orientation of the right is coming off anteriorly, even more anterior than an AL 0.75 typically would ordinarily be coaxial in this location, but I think it has more severe angulation takeoff that we anticipate. And so we may need a guide liner or a guide extension to make that coaxial.
And the beauty is, Ashish, as a CTO operator, is always thinking 3 steps in advance, and we've got those other, that other equipment on the table. Really quickly, before we throw to Alok, what did you do next?
Yeah, so we just wired the
Next picture.
next shot. So we ended up using our game plan worked. You can see we're still coaxial. We didn't take any picture because I wanted to get my guide coaxial and at least get a good angiogram so we don't waste contrast. He's 84 years old. So this is where we are. We were able to pretty much.
Have we not taken a picture with the wire out
Maybe
there?
not.
Now, why don't you take it?
We fluoro saved it, but
Oh,
we can
here.
just, yeah, there you go. There you go.
There we are.
So right now we have a wire in the PL and we have a microcatheter that hasn't crossed that second lesion. I'm going to work and try to get that across, and then we'll pass it on to Alok and let him.
So 60 seconds you get, and then we go to Alok. How's that?
Sounds like a plan. So I have a Turnpike spiral. For those that are not familiar with it, we have a 2E, so I'm going to loosen the 2E. I'm going to pin the wire with my pinky and rotate as fast as I can. And
Which direction are you rotating?
I'm rotating clockwise first in an attempt to try to get this with gentle forward traction on the guide. I'm losing my guide a little bit here as expected. I'm going to clock it, but when I clock it, I lose that position. So I'm going to keep trying one more time here. And if this doesn't go, we're going to switch out to I think we've made some progress.
Matthew, comments while they're working?
So I'm
Yeah, I
trying
think-
really
I
hard
think
here.
obviously it would be great to have more guide supported. Maybe using a guide extension catheter would really help with the traction and kind of pushing
I think
down.
I may be across. Should we take a little test here? If we're across, then I might just switch out. Nope, not yet. So we're nose going in. If we were really in a bind and we didn't have options, then I would accept that position and just take a rotowire here and go for it. But I feel like we'll be able to get a lower profile microcatheter after we've trapped this out. I think
So Dave, I think this is one of those cases where Aaron and Ashish and Bill Lombardi teach that, when you take on the CTO education, becoming a CTO operator makes you a better operator at non-CTO lesions.
let's try the trapper balloon.
All right, we're going to change out equipment here. So I think what's important, let's go over to Alok, and we'll work, Bill and Dave et al., and then when we have something new to show you, you guys can come back here, okay? They got a great case going on next door.
Sounds good. All right. Dave, we're back with you.
I have challenged Ashish with this case. Ashish, tell them what you've done.
Yeah, no.
Going
so-
down that algorithm.
Yeah,
that's,
so we're literally testing the algorithm. I didn't anticipate this to be as difficult. We were thinking this was just going to be a 5-minute case, but my God, this is an interesting situation. I think the challenges start from the guide support, like we were saying. So if you can go back to our shot that we left them with the wire across, or maybe before this. Yeah, so you had this situation. So we got our guide liner and a guide extension down. We had our Sheon Black into the posterolateral branch, and we started with a different microcatheter. So we switched out to a Turnpike LP first, and then we then decided that didn't go. Then we switched out to decided to try balloon-assisted microdissection with a Sapphire. So the learning point here is that any small balloon you use to do a dilatation has to be a 20 millimeter balloon. So you no longer, the you intuitively think that you're going to take a 125/8 or a 125/10, but the mid marker of all these balloons is the largest profile of the balloon. So you want to get that as far into the lesion as possible. So a 20 millimeter balloon will give us at least a 10 millimeter head start into the lesion where we want to hope to actually either dilate or crack or even do BAM, which is balloon-assisted microdissection, or what we used to call colloquially granuloplasty. But the bottom line is we're not able to even just get that balloon past that first tight hourglass lesion. So all the work we're doing is really not even reaching that spot that is where the tightest lesion in the lesion where the microcatheter is getting obstructed is downstream from where our balloons are getting stuck. So that's the problem. So
But what I love is, and we'll make this algorithm available to people, you're 3 steps ahead of where you are. You're always, the lab knows what the next 3 steps are because he's asking for one thing, but he's asked for 2 more things in case this doesn't work to keep the cadence of the case.
Yeah.
And one thing you don't do is perseverate on a catheter. I've noticed if something isn't working, you go to the next step in the algorithm. And I think that's really super important to understand about this case.
yeah, so I think at this point we're at that point where instead of bringing in, if I was in a lab that we could bring the laser in right away, but that takes 5 minutes to set up and it's a little bit more of an issue. And just from a workflow standpoint, we have an OCT, we have the roto equipment in here, it just wouldn't fit in here. So I think we're going to free wire this with a roto. We have a Mamba Flex as far nosed into the lesion as we can. And I have, so I've given up my 14,000th wire and I'm just now going straight with a roto floppy
All
to
right,
free
so
wire.
Aaron is chomping at the bit.
Yeah,
so
go for it. Go for it, Aaron.
I'm going to give him the opportunity
Of course,
to talk.
of
Aaron?
course. Hey, Aaron.
Algorithms are great, but they're not to be dogmatically followed. If you use some reason, 2 people have put 014 wires through this. You really ought to be able to get a roto wire through it.
That's what I'm doing.
Just roto it.
That's what I'm
I
doing.
know that's what you're doing now.
Yeah.
Yeah, and also I think, sometimes you see these kind of cases and like you did initially, you put a microcatheter. The other, Boston is
come
coming out
RAO,
with a
please?
new rotor wire, which actually is even better for these lesions. The CSI wire with a flex tip wire, I've had success in 2 cases where you just put the microcatheter, that wire goes beautifully through this lumen and just
Come
run
back,
the
Elio.
CSI through there and make your case simple.
So, Bill, you've taught me everything I know about rota, and I remember you saying something about how do you keep your burr from not popping through and then getting entrapped. So what's the tips?
Yeah, I think you just really want to push slowly. I think the problem is that people start pushing too aggressively, and if it pops through, then you may get it stuck. Usually not in native coronaries, but when you're trying to do like in-stent restenosis, that can be a real problem. But I think just being patient with these tight lesions. Interestingly, I don't think that the smaller burrs are more crossable. You'd intuitively think that you want to put a 125, but I think actually a 1.5 or 1.75 is better for these. I've had a lot of trouble with 125. Just they don't seem to have as much bite or whatever to get across those tight lesions.
And actually, Dr. O'Neill, the thing that you pointed out is absolutely correct. The shape of the 125 is olive shaped and it actually gets stuck. So it's, again, counterintuitive. People want to use a 125 and the lesion is tight, but that's the situation where you're probably going to get trapped with the stuck burr. And there's no reason to just start with a 1.5. I have never had a situation where the 1.25 was better than a 1.5 burr to get the case started. So my burr of choice is always a 1.5. The only reason to use a 1.25 is if you have a guide extension and you're limited. So for example, a 6 French sheath and then a 6 French guide extension, which then takes you down to a 5 French. Or if you are doing roto in the subintimal space, like for example, we're trying to do a CTO and we're in the subintimal space and then need to use a 1.25 because of fear of perforation.
Ashish, this is a really big right. How often would you put a temporary pacer up doing rota for this?
Perfect. I'll let David answer that question about the temporary pacer. Funny you ask.
We discussed that and then made the decision to give some aminophylline, to give 25 milligrams of aminophylline. Obviously, that is a concern. Now, I tend to be more inclined toward putting a pacemaker in if we are transradial. We'll just do an ultrasound guided access of an antecubital vein and advance it that way. In this case, we decided not to go with that. We have really good hemodynamics thus far with everything we're doing, and so I deferred to Ashish on this one. We did not put it in, sometimes you live to regret that move, but we'll get quick access if we need to.
Yeah.
People in the room have some pharmacology in their top pocket in case it
We need
becomes
to.
an issue.
Exactly. So
And one of the other, this is a teaching case and whatnot, we do
Straighten
have a
this out.
cardiac anesthesiologist giving conscious sedation for this. And that's not day-to-day clinical practice, but it does change my inclination if we have someone that can manage that in the room.
You wanna
But
just
I go with pacemakers sooner than I think Ashish may, but
Nice
it's
rail.
just
Nice
different
rail.
style.
Good, perfect, super. So we're going up with our 1.5 burr here, so.
Yeah, the other thing is, that, is sometimes using a rota extra support wire, especially going through tight lesions like this with a microcatheter works better, and it gives you a little bit more
good?
You're
purchase
good?
when you're going through these high-grade lesions. I usually routinely use rota extra support wire for these.
Yes, I do the same thing. I notoriously use a rota extra support on most of
What's
these
the
rota
one?
cases,
What's the-
especially
what's
if
the
there's some
guide?
difficulty with the guide support like this case here.
You
You can
got
see
it?
the guide popping back.
And you just keep
So I
moving
think
that over like
a
this.
rota
Watch
extra support may
that.
be a very
What's the
reasonable
guide?
idea.
So a little bit tension on the
One
wire.
technical thing is the operators are working on, you have to be really careful about getting
push
the
up.
guide
Tension on
coaxial
the
to
wire,
the lumen.
because my guide's coming
Because as
back.
the rotablator comes out, if you have a kink there, and this happened to
go.
me once, I
Tension on the wire.
amputated the
My guide
wire.
shouldn't
So
come
you have
back.
to be
Lovely.
really careful
Beautiful.
with
Nice
these,
job.
because the guide is really not coaxial right now.
Nice job. Come closer.
Yeah, that's a very good point because you can even stall it.
Come
Because you
closer.
kink and it makes that sharp bend.
Tension on the
You
wire.
go in there in the lesion, you can probably just stall it and
Excellent.
it'd be a
Nice job.
problem.
Perfect.
So.
Aaron?
Mallory's doing a fantastic job of being operator number 2 right now while I talk.
Because it's really key, because, as everybody's been saying on the panel, our guide is not coaxial. So this is the point where being cautious and working in tandem with your scrub is vital. Otherwise, tension on the wire, tension on the wire. You see, every time the guide backs out, there's a risk of the whole thing just flopping out. Tension on the wire, please. Tension, good tension on the wire. All right.
So this is really what I think Dr. O'Neill was talking about. This is a really,
Tension
as
on the
that
wire.
burr comes down, there's a lot of wire that you can't see out in the
Yeah,
aorta.
exactly.
And
So
you're
I'm-
potentially going to kink this, and you apply any rotation to this, you're going to snap that wire.
Yeah, we're just actually just getting coaxial there.
Aaron?
You can see that I'm better off here. There's no more loop in the aorta. We're going to start from here.
Good point. Good point.
Yeah.
We do need rota with IVF.
Yeah, so just going to
Aminophylline?
send you that. Yeah, let's
Here's your aminophylline.
can just get, yeah. So we're just going to give the aminophylline prophylactically here.
Just in terms of the setup of the room while he's doing that, Bill, I want you to see one thing. We are using the Protego system. This is a radiation shield that really does a spectacular job. On the case yesterday, we had 0 radiation throughout an entire case. And I just looked back, and with as much as we've been on fluoro now, we have 0 radiation exposure to the operators.
Yeah, that's just fantastic. I hope that will be more widespread in use. Heart rate looks fine here. Nice
Right.
gentle touches. That is one tight lesion, boys.
Yeah.
I'll take a break.
I think we're maxing out on our length. So what we're going to do is I'm just going to try to advance the whole system.
What RPM are you at now,
We're at
Ashish?
170. Usually I start at 160, 170.
Yeah, I
think.
would ramp that up a little bit.
No, I think
more.
we're running out of room, Jazz. That's not our. So what we're going to do is, this is the technique of advancing the whole system here. We have a little bit of backflow. I think flush is not coming. Open up the flush.
Ashish, can you clock your guide in a little bit now with the rota catheter in the proximal RSA?
It was off. That's all. Good. All right. We're just sorry, Josh. Sorry, Tom. I'm just. That's okay.
So, Bill, I'm really confused. When Maurice Bookbinder was around, we were doing 160, 170 RPMs. And then Mark Griezmann, when he was Maurice's fellow, saw that she had more particles. So we dropped down to
Just let it clear the
145,
conscious.
50. What's the right burst speed in 2021?
I think there's a lot of voodoo and all of that, to be honest. I mean, it's just a lot of what do you decide to do? One comment I would have about the technique, we're using the woodpecker technique here, which is pecking away, and I really dislike that a lot. I'd rather, like when you're screwing a screwdriver into something, just gentle forward, constant pressure for 15 to 20 seconds, and I think you get better atherectomy that way.
While you're out.
Yeah, that's what I do too, but then
need
I
to
learned
take the
everything
brake
about
off.
rotoblator from you, so.
Would you mind just doing one run with the rotoblator, getting it to the lesion
Yeah.
and going at it for about 10 seconds with gentle forward pressure,
Yeah, well, sure.
and then pulling back?
Yeah, sure.
It's interesting how that guy doesn't really help us.
Okay.
You're almost through it.
Yeah. Just getting my wire down.
Excellent point.
So we're running out of room. So one of the tricks that you want to do is when you run out of room, as you can see on this here, is that you got to be able to manage advancing the entire system. And the way you do that is you basically unbreak the wire so the wire is free, and then turn the system on to the same speed that you're at, and then advance the entire system forward. It's a two-man operation. I'll have the TUI wide open, and I'll have Dave advance the entire roto system moving forward so that then we have a new set point that's a little further into the right. This is more relevant. Actually, you can stay on my right, Dave.
Okay.
I think that's going to be more relevant, say, if you're dealing with a lesion in the crux or a lesion in the PD or further down. Surprisingly, because of how our guide's sitting, we're losing a little bit of length because the patient has a pretty tortuous aorta, as well as we're non-coaxial with our guide. So we'll fix that. And once we get that going, we'll get to the lesion and be past it. I don't think the lesion is the issue. I think we're just not reaching it.
How is Alok doing next door?
We were waiting for the RODA, so we just have been sitting here. So what we decided to do was
Why don't we go to Alok while we adjust, okay?
Ashish, can you clock your guide now when you have the rota catheter down?
Are you guys
Give me
ready?
a little more support. Clock your guide in with
No,
the rota.
yeah, it's
for
not, because
approximate.
anytime you clock it, it's like you almost have to raise the guide up to make it sit distally. So that's
There's a reason to use IVL. That's right. That's good, Aaron.
okay, super.
3-0 compliant
So
balloon.
let me show you what we did. Using Bill's technique, thank you, Bill, we finally got the roto down there and did some atherectomy, and then replaced this with our end hole catheter, and then went to a whisper wire. So we have a
Wiggle.
I'm sorry, excuse me, a wiggle wire. And with the wiggle wire out distally, we now have a 3.5 semi-compliant balloon. You want to show that where we're at?
Yep.
And now we're ballooning this lesion. We decided to balloon right at about where that marginal was. There was a lesion there. We're getting nice full profile, which I think is always important after this. And then, what pressures are you using there?
14.
14 atmospheres.
Dave, I'm just curious. When you do rota, do you have covered stents in your room?
Not
or at
only do we
least-
have covered stents in the room, but we have almost rehearsed this. Not almost. We've rehearsed exactly where they are, and the techs here and the nurses here know to
OCT.
have them. Know to have those covered
OCT.
stents accessible, and know the sizes, David, that we have in the room, so that in the event of there's no, oh God, where's the red box?
Is
You know?
Bimal here? Oh, yeah, good.
Yeah, I think that's really, really important. There's not every lab has that, and I think you have to. I mean, not every lab has covered stents, but you have to do the drill, and you got to know where the stents are, and you got to know the sizes. You can't be, oh, here's this one.
Us
when-
using a 2.5, if there's a 2.5 in this room, us using a 2.5 in this vessel would be a placebo, and that could be a disaster. And Bill, we showed a case earlier today. Patient came to us from California, and they had a perforation, and the point was it was a lab bill that was doing roto and everything else with no contract for covered stents in the lab, and that's how the case started. And so not only having them in the lab, but knowing exactly where they are for high-intensity cases like this is extremely important.
And I think it's even more important, David, right to your point, in ASCs. You know, we opened up our ASC this year at Pima Heart in Tucson, and we're averaging about 100 cases a month there. And I can tell you, those are things you really want to have. Coverage stents and a balloon pump are a must there.
In this particular lesion, though, it's a concentric, highly calcified lesion in a large vessel in a relatively straight segment of a coronary. So I think the chances of rupturing with normal sizing, I think, is really almost nil. It can if you really dramatically oversize the size of the stent, but again, I think in this
set
particular
up
lesion,
the-
I'm less worried.
So
And the run?
we're going to do an OCT now just to look at the vessel, see what we've done, do some sizing.
I think, with calcium and a large vessel, I think it's imperative, especially if you're going with a plaque modification strategy with atherectomy, like in this case with just a 1.5 burr, because, sometimes you're limited being radial. I mean, I think it's really, really, really important to make sure that you've actually done something with the atherectomy, and the only real way to confirm that is with intravascular imaging. More likely, better off with OCT if the creatinine is normal, which in this case it is. So we're just going to set this up. And
So let me just give one of these minute-to-minute details. We are still, Ashish and I are still at 0 radiation exposure. With all of this work we've been doing, we're still at 0.
That's just fantastic.
how's that look, Bimal? Everything cleared pretty good, right?
Yeah, everything. Let me go to live view here
Yeah,
so we can see.
So we
Dave,
have-
when will you be able to take your
Just give a little
lead
puff.
off?
Yeah, I'm
Aren't
giving
there
a
going
little
to be
flush.
regulatory issues?
Yeah, the state of
puff.
Michigan, I'm told, with this
Great.
device has given the thumbs up for lead off. We still have some issues to go. Our ACT now is 472. Colin has given me, so everything is really nice and stable and looking very good.
All right, so I'm going to step on Cine, enable, and then go for the run, okay? Cine, enable, and here I go. How is the quality?
Perfect.
Good.
It looks
super.
great.
Can you help us interpret?
Yeah, so let the image kind of appear here, and what we'll do is we'll co-reg the image as well.
Bimal, closer.
Sorry.
That's right.
So let's set up the co-registration here first. The image quality was excellent.
So Bill, this is Bimal Padalia. He's our imaging expert, came to us from CASE, and has really advanced high-res imaging on all of these cases.
Go blue.
Yeah, there you go.
All right, so we're going to let this play. We'll go, actually, let's go from distal to proximal, and you can see in the left corner the marker is co-reg with the actual angiogram. So this is perfect here as you're going through the distal part of the lesion. You can actually appreciate a lot of superficial calcium kind of throughout that.
Wow, look at that.
And then the fracture that you caused, with your roto as well as the balloon. This area, a static image sometimes can fool you. This is a big calcium chunk here in the inferior part of that branch. And then as we continue to play, heavily calcified, this is a really nice characterization of circumferential calcium. We could measure the length of that calcium as well, which is above 5. The length clearly is more than 5 millimeters, and it's circumferential. So your calcium score here is 4.
Yeah.
Really mandates needing atherectomy to get your stent to expand.
Yeah.
And what the other thing we'll do here is we'll try to go as normal to normal as possible.
Yeah.
The entirety of that mid-vessel is actually diseased, but we want to land more in fibrotic tissue rather than lipidic tissue. So around here,
Yeah,
the lumen measurements
2.5.
is going to give you 2.5, and then you can upsize that by 0.25 or 0.5. So
I could go with the
safely you
3.0
can go
stent.
with the 3.0 stent.
That's what my
So
that's
what's your length that
distal.
you want?
I think we're going to need a
And-
48. our longest stent we have, because I think
Yeah.
it goes all the way back, if you see.
Yeah, so if you go all the way back to where your guideliner is, because it's diseased, and
Yeah.
give you some length, we can resize that distal length, because it'll give you the 48.
You're
that will
going
be
to need a
48
bigger boat here.
Yeah.
Yeah, no
And
question.
the mean diameter here is 2.5 lumen to lumen. You upsize 0.5, so
Yeah.
it's a 3.0 diameter stent.
Yeah.
And this will get you a 48 all the way to the proximal part of the
So give us a
LAD.
3.0 by 48 DES, please.
And your mean diameter here, in terms of your proximal reference
It's
segment,
almost-
lumen to lumen is 3.62. You could safely go to 4.0.
Yeah.
Taper it with a post-dilatation balloon throughout, and
Yeah.
then a post-PCI OCT will
Yeah.
make
Can
sure
I just
have
ask you one
perfection.
question, Bimal? Have we adequately modified the lesion at this point, or do we need anything adjunctive, like an NC balloon or anything else at this point?
The tightest lesion currently, this proximal part of the lesion, it does not have, you've got about less than 180 degrees of calcium kind of throughout this lesion.
Okay.
I think right when I walked in this room, you had a balloon up there that showed good profile.
Yeah.
So I think you should be okay.
Okay, good. Thank you. Perfect. Appreciate it.
Ashish and Dave, this is Michael, devil's advocate. So the distal vessel is diseased and small. The lumen is actually 2.5, but you're going to put in a 3.0 stent. What would be the disadvantage of putting in a 3.0 shorter stent distally and a larger stent more proximally? I understand it's
None.
2 stents, but you have a big vessel proximally that you want more like 4, rather than trying to take one long stent and then recontour.
No, I think it's absolutely no arguments from my side. I mean, that's six or a half dozen. I was just trying to be fiscally responsible and use one stent. That's using 2 would not be wrong.
What do you want to do?
We'll just go with 1 3.048.
Okay, we'll go with the 3.048. You know, the beauty about our lab and the choice of stents we have the 3.048 Synergy. We're doing the 48 millimeter trial with Abbott right now. Our workhorse stent forever, both in terms of what we do commercially and in the numerous trials where we've had a comparator arm, has been the Xience Sierra. We're very blessed to have 2, what I think is really spectacular, manufacturers in our lab. Again, I think this is a case, to answer your question, Mike, that's dealer's choice. You could put 2 short, we could put 2 Xience Sierras in very easily. We can put 1.48 in. I don't think it matters, and I think the clinical difference is going to be a wash.
I don't think, Mike, to answer your question, that I think a 3.0, I know you're concerned about the vessel being small, but at lumen to lumen on OCT was 2.62.
Right.
So even if you followed the algorithm, the MLD max algorithm, you would, for OCT, you would at least put in a 2.75. And so a 3.0 at nominal, I don't think I risk a edge dissection. And as far as your lesion and it's got plaque, but it's definitely not. By ultimate criteria, this would be a good place to land a distal stent. So I think I'm not too concerned about an edge dissection.
Okay. Dave, we're about 3 minutes, but we're on fiber optic rather than satellite. So you want to keep going and let people get lunch as they can and let you guys finish up? We can watch it?
Why don't you let us keep her? Why don't everybody go get lunch or whatever wants to watch? And then I do want to go back to Bill. So let's, to Alok, I mean, let's stay on for about 10 more minutes. Each one of us get 5 minutes to kind of show where we're at, okay?
Okay, sounds good. So we're going to stay on, take a bio break at
What do you
about
think,
11:55 and have Dr. Kern do his thing with the panel at noon.
All right.
Perfect
I think
length,
it's
right?
great, yeah.
Right. So we're going to go up here, and we'll get us a 4.0 20 NC for the proximal segment.
And I'm sorry, this is a 3.0.
This is a 3.048.
48
Yeah.
Synergy.
Yep.
You can see it perfectly matches up to your co-registration system in terms of where
That's
to land
great.
the stent.
That's great.
Thank you.
Okay.
Ashish, it looks like it expanded really nicely there. Looks like a
Yeah.
very nice result there, approximately.
How are you, Tom? Didn't get a chance to say hi to you.
It's good to see it, my friend.
So good to see you today. We need to catch up.
Absolutely.
I'm curious from the panel perspective, how obliged are you going to be to do imaging after
Take one last
you've
picture and throw
optimized
over
the
to,
stent?
Hello? Yeah.
Bill?
I think you have to because of the length of the lesion, and you really need to know where the full expansion is going to be. So I'm not so worried about the distal as much as the proximal.
So what we're going to
Key
do is
point.
post-dill this
And image it again.
and image it again. Let's throw over to Alok so you guys can see what he's up to over there.
All right, Dave.
Thanks.
Hi, everybody. So just wanted to give you guys the final OCT run. So if you guys can see it, so distally you can see we landed perfectly, no edge dissection, well opposed. There's an area of malapposition there that we measured, actually a little bit back. Yeah, we measured there. The cross-sectional area was 9.1. So I don't think that needs any further craziness to try to oppose stents. That's one of the lessons you learn with imaging. This is the worst malapposition, and cross-sectional area was 9, and then we keep moving back all the way, and it looks great proximally. We post-dilated with a 4.0, and you can see it's well opposed all the way back, and there's some blood pooling proximally just before the guide. So, and then we'll just show you guys our final 2 completion angiograms. I've taken my wire out. This is the LAO shot. You can see that panning all the way back, no edge, no wire perf distally, and then give us an LAO cranial or an AP cranial. And that should be that. Line us up. Thank you. Here we go. And here you get a true appreciation for how the guide is sitting with the presence of the guideliner and how that was half our problem the whole case. So.
Ashish, that's a beautiful result for a
Great
very
result, too.
technically challenging case with limited guide support. You know, I think you did a phenomenal job,
job. Yeah.
especially bringing the
Great job.
rotor burr when you had your guide hanging out in the aorta, your wire could have been looped, and you could have had wire issues and snapped the wire. So that's a beautiful result with a very, very challenging case. Great result.
So last thing is radiation. We are 0. We're 0 on radiation in this case. That's great with our Protego system. What a nice. I hope that we can get a consortium of physicians together to work on developing studies and research and adding to the body of science of this device. And then also we have the
Sheathless
sheathless
guide,
guide. And what we're going to have to do is put the inner catheter back in there and take this out as a unit. So these Asahi sheathless guides are really terrific guides to use for these cases. Great work, man.
Thank you. That was
Great
a fun
work.
case.
It's
It was a
always
great
fun to
case.
work with you.
Awesome. Thank you, everybody. And enjoy your lunch and have a
Great
great
job,
rest of the
guys.
meeting.
Fantastic case. Great job.
Good job.
Thank you, guys.
All right, we're going to break for a quick lunch, and then Dr. Kern is going to lead a cast of malcontents and characters on lunch conversation.